Okay, so we'll get started as people slowly kind of start to filter in. Maybe they're running to their uh, microwave to warm up their lunch so they can enjoy the session. But welcome everybody, and thank you for joining another DARO speaker series. So um, I just wanted to start off by saying thank you everyone for continuing to join our DARO speaker series. This particular series is about dismantling barriers, focusing on gender equity in healthcare in honor of International Women's Day, which occurred earlier this month. And for those of you who are new to our DARO speakers series, DARO is the Decolonization, Anti-Racism, Anti-Oppression Committee, which stands for DARO at the School of Nursing here. The DARO committee aims to decolonize the School of Nursing's policies, programs, and practices to create an inclusive environment that challenges the colonial way of knowing and doing in nursing education. And DARO is made up of a diverse team of faculty members, students, staff, community, and clinical partners and alums, which I see some of them today online. Um, and our speaker series today will be facilitated by myself, Ashley, and I'm teaching faculty here at the Arthur Labatt Family School of Nursing and our co-chair of DARO currently. Now, one of our goals at DARO is to establish a learning and work environment that is free from discrimination and stigma. And one of the ways we try to work towards this goal is through our speaker series, where distinguished guests and scholars are invited to speak to various issues of inequity in healthcare spaces, like our guests today. But before we begin today's session, I just wanted to start off in a good way by acknowledging the lands that we live, work, and play on. So Western University is located on Betagwaganon, which means outside flow in Anishinaabe Ojibwe. And this is the term a decolonial atlas may use to describe what is now known as London, Ontario, alongside the Deshkan Zabing, which is translated to Antler River, or what settlers have termed the Thames River, which flows through the heart of southwestern Ontario and connects Western University to many First Nation communities. Western University and the Arthur Labatt Family School of Nursing is located on the territories of the Anishinaabeg, Haudenosaunee, Lenapehoik, and Connaughton nations, and the Huron-Wendat Nation also has connections to this territory. London and surrounding area are covered by Treaty 6, London Township, Treaty 7, Sumber Township, and Treaty 21, Longwoods. Betagwaganon, at the side flow, has been in relations with many diverse Indigenous nations since time immemorial. As an uninvited settler with white ancestry, it is essential for me to recognize the historical and ongoing wrongdoings perpetuated against Indigenous peoples and the legacy of colonialism that continues to result in unjust and inequitable health disparities among Indigenous peoples in relationship with Canada and globally. Truth and Reconciliation Commission of Canada calls upon governments and healthcare organizations to recognize and implement the healthcare rights of Indigenous peoples. And of the 94 calls to action, 7 specifically pertain to health, including 22, recognizing and valuing Indigenous healing practices and using them in the treatment of Indigenous clients. 23, increasing the number of Indigenous professionals working in the healthcare field. And 24, requiring that all medical and nursing students take a course related to Indigenous health challenges. As an institution that is educating the next generation of nurses, we are responsible to these calls and must demonstrate our ongoing accountability. And as a nurse myself, I'm responsible to these calls to act. This land is home to diverse Indigenous peoples from whom we must restore as the contemporary stewards. By recognizing this, their relationships with the land, we make explicit Indigenous peoples' presence and their rights to self-determination. Now, the DARO Committee stands in solidarity with the principles of gender equity, particularly as we honor International Day of Women. And this day commemorates the women's rights movement, focusing on critical issues such as gender equity, reproductive justice, and combating violence and abuse against women. It underscores the importance of gender inclusivity in all spheres of life. Nursing as a profession must be steadfast in its commitment to gender equity, ensuring it is respectful and inclusive to trans, genderqueer, and intersex people. We must commit to challenging cis-normativity and heteronormativity, and including trans, genderqueer, and intersex communities. Discrimination in healthcare provision disproportionately affects women, trans, genderqueer, and intersex people, often leading to delayed or avoided necessary healthcare services, often to the point of putting their overall health at risk. Recognizing the historical relationship between colonialism and patriarchal structures of society, we acknowledge its ongoing and deep impact on women's experiences in navigating healthcare spaces safely today. We respect the rights of all people to self-determination and the right to receive healthcare. And as professionals working in this environment, we aim to achieve that. Now, just a quick note on housekeeping before I introduce our distinguished speakers. Please note that the session does end at 1 o'clock today. Please don't interrupt the speakers as they are talking. They've prepared about 10 minutes of discussion, and then there'll be time at the end of the session where all the speakers can have questions proposed to them. And I'll introduce each speaker before they begin. So the first person I'll call on to talk today is Kelsey Adams. She is a gender-based violence educator who has been working in this field for over a decade in London, Ontario. And she actually is a graduate from Western University, and in 2014, with her master's from Women's Studies as a social science and humanities research grants recipient. And since 2019, Kelsey has worked at Western University assisting in planning, implementing, and reviewing how gender-based violence prevention education is taught to students. So please welcome Kelsey.
Hi, folks. Yeah, thank you so much, Ashley, for that, and thank you for the invitation. Yeah, happy to be able to share a bit about sort of some of the work that I do in relation to gender inequity, and how it relates to healthcare. So I recognize that I work in education. I don't work in healthcare, but I wanted to sort of share my perspective. As Ashley mentioned, I've been working in the gender-based violence sector for quite some time now. And so I've been able to have lots of different conversations with students on our different campuses, with community members, with youth, with older folks, around issues related to relationships, consent, experiences of violence, experiences of trauma. And I wanted to kind of hopefully share some of my knowledge with you today. So I think kind of at the base level, kind of an understanding around sexual violence and gender-based violence is super important for your work as healthcare practitioners. Some of what I say may be kind of old hat to you, but I think always a good reminder. But when we think about gender-based and sexual violence, it's really any violence, physical, psychological, emotional, sexual, that's carried out through kind of sexual means or targeting one's sexuality, gender identity, or gender expression, whether that is kind of real or true or just perceived. It's not about sex, it's not about love, it's not about lust, it's about that power and control that someone has over another person. And it can kind of play out in lots of different ways, whether that's stalking or criminal harassment, whether that's in person, online, in kind of cyberspace, if that's sexual assault, if that's, intimate partner violence, domestic violence, homophobic, transphobic jokes or experiences, voyeurism, catcalling. There's lots of different experiences that can kind of go under the umbrella of gender-based and sexual violence. And how I think it really relates to healthcare is kind of two pathways. One is the experiences of gender-based and sexual violence that individuals in healthcare may experience, whether by their colleagues or by clients or patients, which I think is a really unique, tricky situation where on one hand, you have the power as the clinician, as the practitioner. On the other hand, they have the power to harass you. They have the power to say degrading comments to you, and you have to maybe smile or kind of brush it off or kind of stay professional, however we want to define that. And I think that's often a really tricky situation that many clinicians are in. So I think there's the experiences of like just experiencing gender-based or sexual violence in and of yourself, but also the experiences of your patients or your clients or the folks you're working with experiencing that. And how can you incorporate a trauma and violence informed lens into the work that you do? How can you have an awareness that a lot of people experience gender-based and sexual violence? We know that it's around 1 in 3 Canadian women will experience some form of sexual violence, around 1 in 6. Men rates are higher, but we have sort of less concrete numbers for genderqueer, gender nonconforming trans folks. But we know that they experience higher rates. We know that folks with disabilities experience higher rates, racialized folks experience higher rates. So a lot of people experience gender-based and sexual violence. And so you're going to see that in your clients, you're going to see that in your patients. And so how can you have an awareness of that, even when you may not know if it actually has happened to them, or like you may not know any details? How can you still have an awareness of the trauma that they might have experienced and incorporate that into your work? So those are both giant topics for, a couple minutes. But a couple things I wanted to say for sort of the increased risk and kind of the tricky situation that clinicians and practitioners may find themselves in when experiencing harassment or violence at the hands of your patients or your clients. I think one is that it does happen, and that kind of to validate the experience of that, it shouldn't happen, and it still does happen. And think about how you can work with your support systems in your environment. How can you have those debrief moments? How can you create an environment where maybe the person that I'm working with has dementia and is saying things and like isn't intending to cause harm, but it's still having that negative impact on you? So how can you talk with your colleagues and with your coworkers around sort of the issues that you're facing? So having those moments for debrief, I think, can be so powerful and so important. And if we do have kind of leadership, like a leadership capacity in our environment, how can we create some systems and some organizational changes to try to foster a greater sense of safety, however that may look? So is that, you know what, I'm experiencing a lot of harassment by this patient. I'm not going to, this is when my healthcare knowledge, deliver vitals to this person solo, or I'm going to switch it with my colleague because they're not harassing that person, or I'm going to use my colleague's male privilege to my own advantage to be able to help deal with this situation. So being able to kind of create that community of care, I think, can be so vital. And then if we're in that leadership and we have sort of increased responsibilities, how can we change some of those organizational systems to create that community care? The second part for thinking about how can we incorporate community care with our clients and with our patients, sort of thinking through that trauma and violence informed care. So that means that we're recognizing that the people in front of us may have experienced some form of trauma. Perhaps it's related to gender-based or sexual violence, but it could be related to any host of experiences of discrimination, violence, harm. It could, an accident, sort of any overwhelming moment of trauma. And it's kind of a switch in mindset from thinking about like, what's wrong with you? Why are you acting this way? To what's happened to kind of result in you acting this particular way. And so there are things that we can do as practitioners to kind of bring that awareness of trauma into the work that we do. Are there opportunities for increasing choice with the patient or with the client? Are there opportunities where we are being more intentional and being more descriptive in how we're asking for informed consent, and really making that a priority with the folks that we're working with, of like, this is what I have to do. This is, or like, is that okay? This is why I have to do this. This is why I maybe have to touch your back in this way, or sort of perform this procedure in this way. Really providing that information to folks before, so that they can make that call for themselves. Slowing down, sort of recognizing that, yes, we may have lots of patients and sort of our laundry list of things we have to do, but how can we slow down and really making sure that we're going at the speed for our patient and for our client to make sure that they feel comfortable with what's taking place. Recognize the power that we hold in that relationship. And so me, as a practitioner, if I say, I want you, like, when I come back in, I want you to be undressed. Like that's a power move that, like, they're gonna feel like they have to respond to that. And so how can I sort of offer more choice or offer more collaboration in that moment? I also think being really aware of what support services are available within your institution or within your organization and within the larger community. So here in London, we have a fabulous sexual assault and shelter called Inova, which offers great resources. St. Joe's has their own sexual violence treatment center where folks are able to not only get medical services, but also be able to have access counseling depending on sort of their experience with sexual violence, but to know what services are available so that you can share that. The expectation isn't that you're then the expert for your patient or for your client, but how can you be that connector to the experts that are in our community? One resource that I really like, and I'll put it in the chat. It's from a place called Clinic Community Health in Manitoba. They offer a trauma-informed toolkit, a resource for service organizations and providers to deliver services that are trauma-informed. It's quite a lengthy toolkit, but I find it really helpful to be able to increase our understanding of what trauma is and to be able to offer some really practical tools for practitioners to use in their practice. So I'll put that link in the chat because I recognize, again, very big topics, but I thought with all of your your access to folks in our community and the great work that you do, that's what I wanted to share. So, thank you.
Thank you very much, Kelsey, for sharing all of that. And I really appreciate your perspective because I know there's also students on this call that might not even have had their first clinical experience yet. So I think for me, what really resonated is I, even in my teaching as an educator, focus on talking about trauma and violence informed care and supporting clients. But at times I probably don't do as good of a job as talking about my own experiences of this when it has been like perpetrated towards me by clients. And that certainly has happened to me numerous times in practice. And so I really appreciate you kind of attending to both lenses in your discussion. So very much appreciated. And thank you for sharing that resource in the chat. I also just jumped in another resource for anybody that is on here that's looking for clinical tools. Western also has like a couple learning modules on trauma and violence informed care, the equip modules that also might be helpful to individuals as a resource, especially if they're kind of newer to that content. But yeah, we'll move on to our next speaker. So our second speaker for today is Jaleesa Karim, and she's a PhD candidate in Women's and Children's Health Sciences at UBC, or University of British Columbia. And her research really lies primarily in reproductive health, sexual health, and relationships. Jaleesa's PhD thesis aims to better understand the role of endometriosis treatments in relation to pregnancy outcomes. And she's also a National Youth Advisory Board member with Action Canada for Sexual Health and Rights, where she contributes to sexual and reproductive health advocacy. So thank you for joining us, Jaleesa.
Yeah, thank you for that introduction. I did prepare slides, so I'm just going to share my screen. All right, so yeah, I'm going to be talking a bit more about gender equity in the context of reproductive health. Are you all able to see my slides? Okay. Um, So as Ashley mentioned, my PhD thesis is about endometriosis and pregnancy. So I just want to give a bit of a background for that. Endometriosis is a chronic condition in which endometrial-like tissue grows outside of the uterus, and it affects approximately 1 million people in Canada, or about 10% of females. So it's not exactly uncommon. And just like endometrial tissue, this tissue can break down with every menstrual cycle, which can lead to inflammation, pain, scarring, and infertility. There are treatments for endometriosis, but there is no cure. And the main treatments are hormonal therapy and surgery to remove the endometriotic tissue. Some endometriosis patients also get prescription pain medication to manage their symptoms, and those experiencing infertility might get fertility treatments such as in vitro fertilization. So I'm currently conducting a qualitative study where I'm interviewing endometriosis patients in BC about their experiences with treatment decision-making in the context of pregnancy planning. So I'm interviewing people with endometriosis who have either been pregnant in the past 2 years, experienced infertility in the past 2 years, or are currently making decisions about their treatment while keeping in mind that they might want to get pregnant in the future and therefore preserve their fertility. So I just started interviewing people last month. I am not close at all to having final results, but there are some things that have come up already in my interviews and that I've seen in my preparations for the study that I want to talk about. And the first thing I want to talk about is pain. So endometriosis, in Canada, the time to diagnosis from onset of symptoms is about 5 years. In the US, it's about 7 years. In some countries, it's 10 years. That's a long time that some people are experiencing pain and not having an answer for it and not having treatment for it. And part of the reason for that is because of this idea that period pain is normal. So in my interviews, some people have said that they experienced period pain since they were a teenager, but when they brought it up with maybe their mom or their friends or family, they just said, yeah, that's normal, like we all get pain. So no, they didn't think to seek out a doctor to investigate it further. There are also people who did go to a doctor and the doctor said that's just normal. So while it might be normal for a lot of people to have period pain, it's not really normal to be throwing up because the pain is so bad. It's not normal to have to be missing several days of work every month because you can't function and get your daily activities done. I've interviewed someone who said that they fainted from the pain. So those experiences should be recognized as not being normal per se, and that there should be some further investigation into that. But where the gender bias comes in is that studies have shown that women are more likely than men to have their physical symptoms like pain being misattributed as being psychological. So I've interviewed people who have gone to the ER because they've been in so much pain, and the ER doctor just said, oh, you're just having anxiety, and sent them home. And that's part of why it took so long for them to get diagnosed with endometriosis. And when we think about how society generally thinks about pain, we do see that women are more willing to report pain than men, and it's more socially acceptable for women to talk about pain. But that doesn't mean that women's pain is taken more seriously. And I actually think that because of the fact that people believe men can tolerate pain better, or it's less acceptable for men to express pain, that means that when they do express it, they might be believed more often. Like people might say, oh, it must be bad enough for him to bring it up. Whereas with women, they might not be believed as often. I also want to mention that there are higher reported rates of chronic pain in women than men. And there could be so many reasons for that. For example, women are more likely to have an autoimmune disease than men. And I think what we need to do and what healthcare providers need to do is really just believe your patient when they say that they're in pain, because ultimately pain is a very individual experience. We know that the exact same stimulus applied to two different people might be way more painful for one person than another. And that doesn't mean that we should dismiss that person as just having a low pain tolerance, or say that they're making it up, because their actual experience of the pain can be much worse than another person. And what's tough about pain is that you often can't see it. You can't necessarily see when someone's in pain, and with endometriosis, you might not even be able to see it on an ultrasound or an MRI, but it could still be there and could be the main cause of their pain. So people need to be more aware of conditions like endometriosis, and also what steps to take as a healthcare professional if someone reports with those symptoms. The next thing I want to talk about is fertility. So this is actually a paper that I wrote in undergrad for one of my courses and then published in the University of Waterloo Journal of Undergraduate Health Research. So for those of you who are undergrad students at Western, there is a Western undergraduate research journal in health and natural sciences. So something to think about if you're interested in ever publishing a paper. But here in my abstract, I've highlighted the sentence that says, women are especially impacted by the consequences of infertility due to gendered expectations of parenthood and the medicalization of infertility. So what I'm talking about here is that there are higher expectations for women to be parents than men. It's still seen as part of a woman's role in society to bear a child. And this idea doesn't just come from men. Like, many of us also share this sentiment, whether we know it or not. And where fatherhood might be seen as part of a dad's identity, but motherhood is often seen as a mom's central identity, or maybe even her only identity. So women who want to get pregnant but can't often express that they feel like less of a woman. And I've heard this from endometriosis patients I've interviewed who've experienced infertility, that they just feel like less of a woman. And the fact that, pregnancy or a lack of a pregnancy is often clearly visible can further add to these negative experiences with infertility, because it's not something that they can hide. And when I talk about the medicalization of infertility, that's about how fertility treatments are very, very focused on the female body, because that's who gets pregnant. But that means that even when the cause of infertility is because of the male partner, the female partner still gets put through invasive testing and hormones and treatments. So that hyper focus on the woman's body and treating her can sometimes cause women to feel like they're defective in some way or damaged goods. And biologically, I don't think we're going to be changing the fact that pregnancy happens for females and not for males. But some things that we can do as a society are to give better respect to people who choose not to have children, and to stop placing so much emphasis on motherhood as a woman's purpose in life. So just in general, we need to value women for more than just their childbearing capacity. And a little bit more on reproductive choice. And I think pregnancy is a very interesting space to talk about gender equity, because males do not experience pregnancy, so it's not like we can directly compare their experiences. But when it comes to reproductive choice, I've heard from endometriosis patients that sometimes they're not offered excision surgery to remove the endometriosis unless they're wanting to get pregnant shortly after. So sometimes they will even lie to the gynecologist and say, yeah, I want to get pregnant, so just so they can get the surgery. And this is a surgery that often reduces pain levels afterwards. So we see these competing priorities of what the patient's priorities are versus what the healthcare provider's priorities are, where the patient might be prioritizing their pain and quality of life and improving that, but the healthcare provider might be focused on fertility. I've found that even though many endometriosis patients would prefer to preserve their fertility, all other things equal, for those who do have a lot of chronic pain, that tends to be their priority because they've said that how can they have a child and take care of a child if they're in pain all the time anyway? So while they would like to get pregnant and have a kid, it doesn't seem reasonable given the circumstances, yet that's not always considered by their healthcare providers. Also, when it comes to surgeries that could potentially end their fertility, like a hysterectomy or an oophorectomy where they remove the ovaries, we still hear stories about women getting denied because, oh, you're still too young, you might want to have kids later, or asking for the husband's consent. And this is another space where women's choices are not always respected, even though they are full-grown adults and should be able to make that choice. And when it comes to pain management, again, we can't directly compare experiences, but I've seen stories of IUD insertion can be very painful for some people, and oftentimes they're not offered pain management for that. Whereas for a vasectomy, men are often offered pain management for that. So perhaps a bit of a double standard there when it comes to pain management. There's also a lot of stigma around prioritizing the mother during pregnancy or childbirth. So a lot of people believe that the child's health should be prioritized over everything else. There's stigma around taking medications during pregnancy, even though those might be medications that the mom needs to stay in her own good health and to function properly. There's stigma around having a medicated birth, getting an epidural. So overall, I think there's just a lot of judgment around women's choices when it comes to reproduction, whether they want to have a child or not have a child, whether they want to have a medicated versus unmedicated birth. Even the age at becoming a mother. Sometimes they're told that they're too young and they should establish their career first. But then when women try to get pregnant later on, maybe in their late 30s, then they're told, you're too old, you should have tried sooner. And even things like birth control, some people say, why are you putting all those hormones into your body? But then if someone has an unplanned pregnancy, then they're shamed for not being responsible. So again, I just think we really need to give women more space to make choices around their own bodies without judging them for their choices. And just to move on a bit, I also wanted to quickly mention my work with Action Canada for Sexual Health and Rights. So I'm on the National Youth Advisory Board. Some initiatives I contributed to were giving feedback on a national STBBI testing awareness campaign. Like they're running things like Instagram ads to encourage people to get tested, giving feedback on the Sexual Health Information Hub that's hosted on Action Canada's website. We've also started to establish a student sexual health services network with sexual health providers from different institutions across Canada. And I was also part of a working group that contributed to the Canadian Contraception Policy Atlas that looks like this. There's also an interactive version online, but basically we helped decide what we were going to score the different provinces on and how criteria would be weighted, and gave each province a score on their access to contraception and information about contraception. And it looks like this. There's this big chart here. And that was last year, and I'm happy to say that, for those of you who don't know, the Government of Canada has announced the first phase of universal pharmacare that's going to include access to contraception and diabetes medications. So here I just want to mention that there's different ways of doing advocacy for whatever you want to advocate for. And for some people, that looks like going to protests. For me, I think it looks a little bit more like doing some research, doing some more behind the scenes stuff, and also just talking about these topics with friends and family and bringing more awareness to it, I think can also be a form of advocacy. So yeah, thanks for listening. I've put my contact information here if anyone wants to reach out. But I will stop sharing my screen now, if I can navigate back.
Perfect. Thank you, Delisa. That was a really interesting talk. I really appreciated even just your comments about the way we may think about things and not know it. Even just experiencing having kids myself and some of the pressures you put on yourself, I think it kind of lays bare to a lot of the challenges that do exist for women in society surrounding reproductive choice and the pressures that we put on ourselves individually surrounding that. So that really hits home for me personally, that commentary. And thank you for sharing all those fantastic resources. I certainly actually use that Canadian Conception Policy Atlas in my course this summer. So know that your work is going to good places. So I'll invite our last speaker for today's session, and thank you for everyone for staying on. Dr. Maisha Saida is a licensed clinical child and adolescent psychologist in Ontario, and she holds appointments as a staff psychologist in the Division of Adolescent Medicine at the Transgender Youth Clinic in the Hospital for Sick Children and in the Intensive Services for Youth at Sick Kids Center for Community Mental Health. Dr. Saida is also an adjunct research professor at Western University, and she researches in the areas of health equity in hospital settings and integrating anti-oppressive and inclusive clinical practices into psychological intervention. So thank you for joining us today.
Thank you, Ashley, for the introduction, and thank you, Kelsey, for extending the invitation and creating the space to talk about gender equity. I think, as Kelsey mentioned, we can spend hours having conversations and discussions about how to conceptualize and act on gender equity in healthcare places. To give a bit of more of a background, over the past 4 years or so, my research scholarship has been mostly in developing and implementing both trauma-informed, violence-informed, and anti-oppressive interventions for refugee adolescents. I still do some work in that area, but as I had been mentioned, I do want to, in this space, I do want to highlight some of the work at our gender clinic at Sick Kids, and for our nurses, our leaders in equity in healthcare settings. So for future nurses, what are some things to sort of consider and pay attention to as we work with gender minoritized and gender diverse youth? So I think for some of the things that I even acknowledge as a psychologist and to other healthcare providers, that whether it has been our environment and wherever we are from, and or even our very official curriculum, our knowledge has been very much based on cis and heteronormative information. And for many, many years, for many decades, gender diversity or gender minoritization or gender nonconformity has been taught to us as a pathology. So even unconsciously, what we have been taught, what we have been told as intervention and prevention and assessment is through a lens of heteronormativeness, cisnormativeness, and there has been either indirect or direct preaching that gender diversity is a sort of form of pathology. So I think that as we sort of prepare our next generations or continue to work with our current healthcare providers, we need to acknowledge that there might be bias and privileges within our brain, within the way that we speak, the way that we communicate, the types of expectations or formulations that we make of people who are gender diverse. So as we begin to become more gender informed, there is professional pathways, but there's also personal pathways. So as a healthcare provider, it's really important for us to reflect on the biases that we might have. And not that I am a really bad person because I have these biases, but come from a point of compassion and hope for you that, like, okay, let's acknowledge that these biases has happened. And it's not that I am this really bigot for having these biases, but really understanding the knowledge and sources as to where these biases have been formed, but also recognizing that there are gaps in the way that I was trained in order to provide services to gender diverse youth. Because I don't know about you folks, but even when I went to graduate school for my clinical psychology, there wasn't even a lot of courses on gender development. The information that I was given about gender development is very much on a very heteronormative, right? Masculinity and femininity. So I had to go back and do my own training to really understand gender development and how do I support our gender diverse patients in our clinic. Another thing that I see in healthcare settings across the globe is there's sort of two things that there's a tension and two things happens, which is both problematic in terms of how we formulate, do assessment, and create treatment plans. There is on one side of the pendulum where once folks sort of see their medical charts and see that sex assigned at birth is different from the name and the pronouns that the patient is using, there might be an immediate pushback or pause, or the over tendency of trying to attribute or explain all their presenting problems from the view of this gender identity, right? So, oh gosh, things must have happened, or maybe you're thinking it this way, maybe you're not making decisions, maybe you have all these psychopathologies, do we need to refer you to all these places? But on the flip side, I also see healthcare providers who, during their entire formulation, their charts, their treatment planning, has not recognized that maybe we need to also understand that this is a gender diverse youth, right? Understanding that how are their experiences? I work with adolescents mostly. So how are their experiences in the bathroom? I'm sorry, at school. But a case example would be that I often do collaborate with the medical team. We have a youth who's having a lot of GI problem, a lot of constipation. But as I was doing the review, nobody has asked this youth the question that, hey, you're having constipation problem. Do you have access to a gender neutral washroom in the school? Even if you have access to a gender neutral washroom in the school, is it at a place where you feel comfortable to go to? So rather than putting all the intervention, like we need to really teach this youth about more GI related interventions, but some of those socio-environmental, barriers that, hey, like what comes in the way of you using a bathroom consistently? For this youth, and I know this because I'm their psychologist and gender is the forefront of our care, is yes, he does have an access to gender neutral washroom, but it's right beside the principal's office, right? So, but this youth does not feel comfortable, always going to the principal's office because it becomes a public knowledge when is he going to the bathroom. So, but and I think for the GI team, this was a really important consideration that, like constipation has become a problem because you don't really have a consistent or easy access or equitable access to a washroom in your school. So again, and I think one of the things that why the pendulum shifts from one side to another, one side that over pathologizes the gender identity, or one side that does not consider the gender identity experiences, is I think it's our lack of training and lack of guidance and mentorship that we're being provided to provide an equitable care for our gender diverse youth, right? I often work with hospitals to think about what are some mandatory training and courses and supervision and mentorship that has to be incorporated, not just at gender clinic, because our gender diverse patients will access everything in the hospital. So it's not that the gender clinic, we need to be trained in everything. Everyone needs to be trained how to work with a gender diverse patient. And from a system level, from a policy level, we need to provide training, we need to provide coaching, we need to provide supervision, we need to provide consultation as to how our formulation, our assessment, our intervention, our prevention needs to be modified. How do we ask the right questions? What questions are important to ask? What are we asking questions because I am just nosy and curious, or am I asking questions because it's a clinically appropriate question? The reality is, what I also see is many of us have spent a lot of years mastering the best clinical practices. We know what are the best clinical practices are, but somehow, maybe because of our own discomfort, lack of training, lack of exposure, not only in gender diverse youth, I also see this in racialized youth, that we compromise on the quality of best practice that we have the knowledge to do so. Whether there is systemic barrier or personal barriers, the best practices sometimes are not being delivered. So as future nurses or existing nurses, I think folks might have heard of Rainbow Ontario. They have great courses for healthcare providers. Maybe if you're working in a clinic, if you're working in a hospital or any other places, maybe it's an initiative that you can even take as a group of colleagues as to what are some courses we can take as a team, what are some external consultations we can integrate, what are some additional supports that we can lean on to in order to provide equitable care. I'm going to stop here because I am cognizant of time, but happy to answer questions of anyone here, or also feel free to reach me as well. Thank you.
Thank you for that, Dr. Saida. I think what really is kind of hits home, especially, is just being really aware that we're going to be evolving in our profession, especially for the students that are on this call, where, you know, what we're learning now might really change in 10 or 15 years from now, and to continue to practice that critical reflexivity that you spoke to, and how we can really continue to provide that safe and inclusive care for all of the people that we're caring for. I certainly, when I was in nursing school, was not learning about the things that we're teaching in nursing school now, definitely not. And also recognizing that that will continue to happen and evolve. So I really appreciate that. So I can open up the floor to questions if anybody has any questions for our speakers. I see one hand. Jeanette.
Hello, everybody. Thank you so much. And really, I would love to have an hour with each of you. But my comment, it's more of a comment than a question, especially for students that might be joining us. Dr. Saida, I hope I said that right. It's just some of the things that we're coming across in placements in clinical settings now in relation to gender diversity is that increased awareness and the increased presence of people from more gender minorities. I'm not sure if I always say the right word, so correct me. I'm hoping this is a safe place to get my words mixed up. But I've had transgender women that have been increasingly frail and elderly and come in with bladder infections, and the team totally misses. I totally missed. There's a prostate still in there. So my treatment and antibiotics and ways of managing that are going to be so different. We also have transgender men that appear with uterine cancers and illnesses related to that. So the way we manage that person is going to totally be different. I shouldn't say totally different, but it has this nuance that we have to add into that. And lastly, most recently, I had a patient who is the non-binary gestational parent of an infant. And that comes with a whole different lens. Pink blanket, blue blanket, huh? Like, mom and baby unit, what? So I really, in London, we've been doing a lot of work in the community, between the transgender clinic here and the different hospital and organizations and primary cares. But we really have to use this lens, not just for our youth and adolescents, but throughout the spectrum of age. So I thank you for your comments there, and the direction, the reminder to go back to Rainbow, Ontario for those learning things. It really is amazing. So thank you.
Really welcome, Janet. Yeah, I think even to really unlearn, it will really unlearn the binary of genders, right? It's not that, right? We're not even thinking about like, male organs or female organs. It's sort of like these are individuals and just a checklist of, yeah. And it's hard because we have been taught in certain way. And when we're busy and stressed out, we go to that automatic old ways of how we have been taught. So no, I really appreciate your comment, Janet. Thank you.
Just also just shared in the group, but it looks like I double shared it. And for the nurses in our program, you don't have to do this because it's going to be part of your course if you haven't already done it, one of our required courses. But for others on the call, even I think Jeanette, you brought up a really important point about this needs to be presented across all spectrums. Often in clinical education, one of the errors that a lot of educators will make is that they exclusively teach inclusive gender approaches when they're talking almost exclusively about like STBBIs, and not also talking about it when you're caring for a client with congestive heart failure, right? And so the module I just shared with you, we work with our students, but we do it with our students, but it does exactly what you're just speaking to, in that it's trying to attend to this across various health conditions where we're not just only concerned with an individual's sexuality per se, but other health conditions that it's kind of like seeking to address exactly the issue that you were bringing up across practice contexts, and not only making it with youth and not only making it with clients related to their sexual health. So thank you for reminding me of that. And I see in the chat, there's a question for Delisa. Is it just the older doctors that ask the husband's opinions on the women's endometriosis concerns? Then how would we change or correct the doctor's way of thinking?
Thanks for your question. I haven't asked, when people have told me that, I haven't asked them how old their doctor was, so I don't know if I can answer that directly. I don't know if there's any studies out there about that. I wouldn't be surprised if it's not just the older doctors. I think, we also learn from, you have your preceptors, you have your professors that you learn from, and sometimes you, as Dr. Sayeda was just talking about, sometimes you need to take a step back and consider how the things that you've been taught might not be the way that you actually want to go about doing things, and to actually take some time to think about how your biases might show up in your work. In terms of how we would change or correct the doctor's way of thinking, I think there's so many areas where, there's conversation about maybe older doctors not always being up to date with some of the new information and new practices. At some point, the doctors have to be willing to change. We can host all these workshops and speaker series and put all this content out there, but I think that going forward, adding some of this content into nursing schools, into medical schools, so that the next generation of doctors and nurses and healthcare providers have these tools and knowledge available to them, might be the more effective way of going about things.
Can I jump in? I think, yeah, just building off of Jaleesa's comments, I think That could be another opportunity for like bystander intervention and using some of those skills. So a classic way of remembering different bystander intervention strategies are the 5 Ds: distract, delegate, direct, document, and delay. So you could directly call out the older doctor and be like, hey, that's a messed up thing to say, or like in whatever kind of professional term you want to use. Or we can maybe document, and we're like, oh, we're gonna make a little note of these comments that this person is saying because it feels like it's crossing the line and I want to create a document of it. Maybe I use delay and I go to the patient afterwards and say like that was kind of a wild thing for them to like mention your husband. That doesn't impact your level of pain. How are you doing? So delaying and talking to them. Or we could go to, we could delegate to like a senior nurse, sort of another doctor, someone who can maybe like has more of that authority that we can rely on and say like, hey, I heard this. Can you do something about it? Because I don't feel like I have the position or the power to say something. So using some of those bystander intervention skills could be helpful.
We can take maybe one more question if anybody else has one. And thank you for that, the 5 Ds. Okay, Zoe.
Thanks, everyone. Just adding to Kelsey's point, so I actually have endometriosis and a variety of kind of marginalized social identities, and have often experienced being gaslit or dismissed in the medical field. And one thing I found really helpful and kind of healing for myself was writing an impact statement to my physician and reading it to them, because I was prescribed a medication that really had a negative side effect, and they didn't really consider kind of a holistic perspective of my health history. So I wrote an impact statement, read it over the phone to my physician, and printed a copy, brought it in, and he was so receptive to it that he brought it to his staff. So this was at a fertility clinic. And I was very lucky, and I am very privileged that I have resources and tools and support to do that. But I think a lot of the times people assume, well, the doctor knows best or the healthcare provider knows best, but really they should be working for you, especially as a person that lives with chronic pain or a variety of other conditions. It really, you need to have a kind of a rapport. And I know that there's such a push to work towards kind of patient-centered care, but that often ends up on the shoulders of patients instead of clinicians. So another reminder there. So not necessarily a question, but just a comment.
Yeah, and I like how you mentioned that the doctor shared your feedback with the other doctors because um, for those healthcare providers who might be a little bit harder to reach directly with the messages that we want to get across, if their colleagues are around them are changing the way that they do things, then they may also recognize that. And that also ties into what Kelsey was saying about the bystander intervention as well, that maybe as a nurse, if you're comfortable speaking up when you see stuff like that and just sharing with your colleagues.
Yeah, thanks for sharing that, Zoe. You know, I would echo Jeanette's comment there that that was a really brave thing to do. But I think it probably, you know, as you said, like it's nice to hear that they were also receptive and led to a lot of growth for hopefully that individual and their whole team. Um, and I think that kind of goes back to some of our other questions around like how do we change people's way of thinking? And that's a that we could have numerous Zoom calls on that because it's really quite a difficult thing to unpack in healthcare and creating those safe and brave spaces, and it does require people to be brave. But yeah, recognizing time and everybody's time is precious. We are at the end of our session, so thank you everyone for coming and sharing about such diverse things. I think we'll all leave and have some period of reflection just to think on how some of this might intersect with our careers as nurses and how we can support clients moving through safe and healthcare spaces. So very grateful for everyone sharing, and yeah, claps. You don't ever see you don't hear the virtual claps, so they don't always feel as just, but you can do virtual claps. And thank you very much for your presentations today.